All right, so today starts the trauma portion of our course. So in the books that we're currently using, it should be chapters 14 and 15. So damage to internal soft tissues and organs can cause life-threatening conditions. So internal bleeding results in shock. Shock is a state of collapse of the cardiovascular system that results in inadequate delivery of blood to the organs. Now, I've seen that quite a bit on tests. Okay, so if you ever see a question about, explain shock or what is shock, shock is a state of collapse of the cardiovascular system that results in inadequate delivery of blood to the organs. So anything that causes blood or oxygen to get to the cells, you will start to go into shock. Okay, so it's not just bleeding shock. It could be something to do with the airway. It could be with diabetics who aren't getting enough sugar and the cells can't process the oxygen due to not having the energy to do so. So not everything about shock is about bleeding. There's lots of things that can cause shock, and we're going to learn about that. So more trauma patients die from shock than any other condition. So what that means is you might get shot or get hit by a car or something happened and you are going into shock. And sometimes the body has this way of progressing through. Okay, so as let's say you're bleeding out and our canister is starting to get lower and lower, once you get to a certain threshold, you will start losing the cells to damage. They will die. And once the cells die, they don't return. Now, skin and muscle cells and that kind of stuff, those can live a long time without oxygen. Once your liver starts to shut down and your kidneys start to shut down, even if we get you back and we get you to surgery and we've pumped you full of blood, a lot of times once those have already started to shut down, most people will end up dying anyway. So that's why when they talk about time is tissue, and that whole golden hour to when the incident happened to surgery, that's why it's very important, because sometimes, even if we get all this stuff, it won't matter just because the vital organs have started to shut down. So really the patient assessment sequence doesn't change a whole lot. So obviously, if the person got hurt doing something, you need to definitely be sure that your scene size up is there. Okay, scene safety for you and your crew. You may need to halt the primary assessment if the patient is losing too much blood. So as we talked about a little bit, pulsating blood or severe bleeding trumps everything else. Okay, and I know we talk a lot about airway breathing, circulation, and then of course, CPR, which kind of trumps everything. But if you have blood that is squirting out, pumping out, it doesn't matter how much CPR you do because you're just going to be pushing that blood out. So any type of severe bleeding, especially arterial bleeding, that needs to be taken care of first with a quick tourniquet, which we'll learn about. So you need to halt the primary assessment if the patient is losing too much blood. During the secondary assessment, be alert for signs and symptoms of shock or internal or external blood loss. When performing a reassessment, watch the patient for the following signs and symptoms. So we know the shock trifecta, right? is cool, pale, clammy, right? So increasing pulse rate, that is actually an early sign of shock. So initially they call that compensated shock. That's when the body is kind of going, whoa, what just happened? All right, I'm going to increase my blood pressure and I'm going to increase my pulse rate just to make sure everything is still getting oxygen where it needs to go. Okay, so that is called compensated shock. So you find somebody who, was shot or bleeding or whatever, and you're like, geez, his blood pressure is actually elevated. Well, that's why, because the body is trying to compensate for the damage. So obviously, standard precautions. So bodily fluids are potentially infectious. So we wear gloves, goggles, gowns, whatever we want to wear. So parts and function of the circulatory system, just a little review here. So um, everything goes into the right atria, then goes into the right ventricle, which then gets pumped to the lungs. We take a deep breath and we get rid of some things. Then it comes back to the left atria, left ventricle to the entire rest of the body after that. Okay, so the pump, the heart functions as the human circulatory system's pump. 4 chambers, two upper, two lower. This is just kind of some review here. And of course, right off of the left ventricle is your aorta, correct? That is that big, huge artery that is supplying blood to all parts of the body. You can see that at the top of this picture here, those are going up to your brain right there. And then down your arms, all down your body. And the pipes. So the arteries carry blood away from the heart. The capillaries form a network that distributes blood to all parts of the body. Okay, so it's in these little tiny arteries that uh, or capillaries that you can see oxygen is being delivered. So once again, if you look at your fingernails, or really any part of your body, but it really shows up well in your fingernails, and you give them a squeeze, they should turn white and turn right back to pink. Okay, excuse me. Those are your capillaries, and that's capillary refill. And then veins return blood from the capillaries to the heart. So in the blood, we have the plasma. Okay, this is the liquid that helps everything move. Your red blood cells carry oxygen and carbon dioxide. White blood cells are your infection fighters, and platelets are your clotting factor. And as you remember, when you guys are on scene and you're watching, the doctors or the paramedics hooking up fluids, that fluid that we're hooking up is only there as a volume expander. Okay. It doesn't have, so the saline that we carry, or you may hear the term lactated ringers, or they call these crystalloid solutions. Uh, they do not carry oxygen. Okay. So all we're doing when we're pushing fluids into people is we are helping to carry what blood and oxygen is left in the system. Okay, they still need a doctor, they still need surgery, they still need whole blood. Ambulance, we just don't have ways of keeping blood good in an ambulance. So that's why we won't ever be, bringing blood to scene unless, they get it from the hospital. So a pulse is the pressure wave generated by the pumping action of the heart. In a conscious patient, you can easily find the wrist, the radial. That's not always true though in a conscious patient. If the patient appears to be in shock or is unconscious, then we attempt to locate the carotid pulse. So once again, shock is defined as the failure of the circulatory system. Circulatory failure has many possible causes. So pump failure, pipe failure, and fluid loss. And we're going to talk about those. So pump failure, now our pump is our heart. So cardiogenic shock occurs if the heart cannot pump enough blood to supply the needs of the body. Pump failure can result from a heart attack. Inadequate pumping of the heart can cause blood to back up in the vessels of the lungs, resulting in congestive heart failure. So if you think of anybody who is having a heart attack or even just having angina, okay, which is not a heart attack, but blood isn't getting to where it needs to be, what do they look like? Well, cool, pale, clammy, right? So that is when you're having a heart attack and you look like that, that is shock. So cardiogenic shock. So then pipe failure. So you're thinking, well, our vessels, those are our pipes. How can that cause shock? Well, pipe failure is caused by the expansion of the capillaries to as much as 3 or 4 times their normal size. So if you think about it, we're a can of pop, okay? And that can of pop creates enough pressure to make 120 over 80, okay? That's our blood pressure. Now, think of that can of pop with 12 ounces of liquid in there. And now that can of pop just expanded 3 times, but there's still only 3 or 12 ounces of liquid. Okay, can we still create pressure with only 12 ounces of fluid, but our pipe has expanded 3 times? Okay, so that's going to drop our blood pressure, and then in turn we're going to go into shock, and if we don't fix that somehow, we're going to die. So here's a few types of pipe failures. Shock induced by fainting, or they call this psychogenic shock. So fainting is a short-term condition that corrects itself once the patient is placed in a horizontal position. So when we talk about shock, something with adults especially, kids can kind of maintain at that really high level, and then it's like all of their cells just go down at once. Okay, whereas adults, we kind of go through that little series, so we start compensated. Okay, and then the body starts to shunt blood from areas that it doesn't need. So the skin, okay, it starts to shunt blood, and the whole idea of shock is the body is trying to keep the core alive. So your brain, your heart, and your lungs, it's trying to keep that alive. So it's going to shunt blood from your skin. Okay? That's why you look pale. And then if you think, well, our sweat glands are in our skin. So, well, without any more neurological control, because all the blood just got shunted from your skin, now your sweat glands are just free to release. Okay, so that's why you look sweaty. And if you've ever seen somebody going into shock, yes, they're sweaty, but they're cool. They're cool to touch, so it's not like they're hot. So, and that's the other one then. Now that you've lost blood to your skin, now you're cool to the touch. Okay, so shock induced by fainting, psychogenic shock. Fainting is a short-term condition, and usually this will correct itself once you lay them flat. So the only problem with this is sometimes you don't correct. So if you've ever heard the term scared to death, and you think it's funny to go and scare grandpa or grandma, yeah, you could kill them. Just just keep that in mind. So my grandma will faint at the sight of a mouse, and I'm not even kidding. Okay, that's how bad it is. Some people faint when they get shots. Some people faint at the sight of blood. Okay, that is all different kinds of psychogenic, so mind created, right? Psychogenic shock. Now, if you ever want to know what it's like to go into shock or that feeling of shock, imagine yourself at a movie, at a scary movie. And of course, the lights go out and the scary music is playing, and now they have to go down to the basement, right? To check out the weird noise down there in the pitch black. And then, of course, something jumps out, right? And what do we all do? We go, oh, man, that was scary. Okay. And if you think about it, what happened? Our heart sped up. We could feel that. We started breathing a little bit faster. And then, that cold feeling that kind of goes up and down your spine. And then sometimes you can even feel the hair on your arms stand on end or on the back of your neck. Okay, for that split second, blood got taken away from your skin. Okay, your body went into shock mode for just that split second. Okay, now for us, that's fun. Okay, oh man, it got me. Whew, that was a scary one. So, and then we calm down and we finish watching the movie. So, some people who maybe have heart issues don't correct. So that's why, when you sometimes you see on certain rides or certain movies, they may say, people who have heart conditions maybe should take precaution. Okay. And that's why, because sometimes, you could go into shock and you don't recover. Most of the time you do. Okay. But I'm just saying sometimes it can be difficult for some people. So quit scaring grandma, you guys. So another form of pipe failure is anaphylaxis. Okay, and this is like a um, bee sting or peanut allergy. Okay, shellfish. So once you get that reaction, and we'll just call it a poison into your system, your body uh, is going to try to fight it off. Now, sometimes pipe failure too, you might see anaphylaxis sometimes is called hot shock. Okay. And that's because sometimes when your vessels dilate, okay, your capillaries dilate and they dilate for a long time, the blood pools in your capillaries. So sometimes your face can get really red and your skin can actually get really red. And that's because things are starting to pool in the capillaries. Now, with anaphylaxis, okay, you just got stung by a bee. Um, Once that poison starts circulating into your system, okay, it's going to cause your vessel walls to expand. Okay, so that's why when you have a severe allergic reaction, losing your blood pressure is only one part of the problem. Now, yes, histamines are released. Okay. And that's because now your white blood cells want to get to places to start fighting this bee sting venom or whatever you're allergic to. So, but it is a hyperreactive response. So that's why you're going to start to swell and your airway can start to swell. So now you've got pipe failure because they're expanding and your airway is starting to swell, your tongue and your face. So if we think about anaphylaxis or a bee sting or whatever you're allergic to, what do these people need? What do they need to correct anaphylaxis? Any thoughts? Well, they need epinephrine, don't they? Okay,
Right,
so
Madeline.
people talking about I carry an EpiPen, that's what it is. So epinephrine or adrenaline, okay, that's why they carry that because what an EpiPen will do is you give that shot of epinephrine, and that is going to constrict those vessels back together. Okay, so number one, that's going to increase the blood pressure. That's good, right? Because we're losing our blood pressure. Number two, it is going to dilate the vessels in our heart and our lungs, so blood and oxygen can get where they're supposed to need. And now for that histamine, it's going to help to circulate and get rid of some of that. Okay, so that's why epinephrine is very, very important for people when they are going into anaphylaxis. So uh, don't wait. Now, somebody goes into anaphylaxis. Okay, don't wait for their throat to swell. Okay, don't wait for them to collapse. Don't be afraid to use the EpiPen. Okay, and it's just a matter of popping off, and next time I'll bring one. Okay, but it's just a matter of popping off the back and popping off the front and injecting. So once we do that, we just hold for 10 seconds. It can actually go through a pair of jeans, and that will circulate, and it works really, really fast. Okay, so don't be afraid. Now, even on a person who is not going into anaphylaxis, if you inject them with that, it's not going to kill them. Okay, it's not going to really hurt them. So don't be afraid to give somebody. Okay, they say, I'm allergic to bees. I just got stung by a bee. I have an EpiPen. Will you help me? Yes. Okay, don't be afraid. Don't wait. Okay, if that's what they say, give it to them. So I will tell you an interesting story about uh, anaphylaxis, and this is a true story. I actually talked to this guy. So it was many years ago. I was at the gym at the YMCA in Grand Forks, and just struck up a conversation with this guy. And I told him that I was going. I was an EMT and I was going to paramedic school, and he talked about, well, I was an EMT, and he said I was also a Navy corpsman. Okay, now Navy corpsmen, they really know a lot. Okay, they teach Navy corpsmen. They're even doing basic surgeries now. Okay, lots and lots of things, that sutures and all kinds of stuff that a corpsman can do. But in civilian life, he was an EMT. So this is the story that he told me. He was at a bar in middle Minnesota somewhere, and he said that uh, first responders or EMRs were 10 minutes away, and ALS paramedics were 15 minutes away. And he said a gal got a nut in her drink. And I'm thinking about that, and it's like, well, if you guys have ever had a bulldog, sometimes they do put hazelnuts in there. So that's what he said. She said, or he said that she got a nut in her drink, and he said that she swelled up immediately. Okay, they called 911, and everybody knew how far away they were. Now, if we remember, 5 minutes without oxygen and brain damage starts. Okay, 10 minutes, and that's the point of no return. You are brain dead. Okay, at that point. So, what he did was he took out his little pocket knife, and in the trachea here in the front of your throat, he made a little incision, and he put a couple of bar straws in there, and he kept the airway open, and she survived. Okay, but what he told me was she got a really bad infection, and she sued him and won. Okay, and not only did he lose that battle, that court battle, but he also lost his EMT, because that is not part of the EMT curriculum. So, kind of an interesting life lesson there when I talk about, you know, is this drug going to help somebody? Can we give it? And I keep telling you, no, we don't want to be a part of that. So here this guy is, who probably had done it before. He'd probably done that before in the military and did it correctly and kept her breathing, but look at what he lost because of it. Now, I don't know the whole story. Okay. I don't know if maybe she wasn't going into anaphylaxis and he was just showing off to his friend. I mean, I don't think so, but yeah, I don't know all the circumstances, but just a really interesting story that I will forever have in my brain with what happened. So good for him. He said he had no regrets doing it, but yeah, that's what happened after he was done. Okay, so more with pipe failure. They call this spinal shock. May occur in patients who have sustained a spinal cord injury. Okay, with a spinal cord injury, that also can cause your vessels to dilate. Okay, dropping your blood pressure. Now, this is going to sound kind of funny, and I'm going to put it as a test question. So, just so you guys are actually here and you're listening and paying attention, um, there is something called a priapism. Okay. And what that is an erection. And it is an erection caused by spinal shock. And if you think about it, okay, the neurological damage from injuring the back, now blood is pooling everywhere in the capillaries. And where does the blood have to go? Okay, well, that's where it's going to go. It's almost kind of like, when you use Viagra or Cialis, where's the blood going to go? So anytime you have a person who fell, got hit, whatever, and you're doing your head to toe assessment, which we'll talk about, and and I've only found it in my career, I have found it one time. Okay. But if you find a male with an erection, I promise it is not because they're happy to see you. Okay. That is a very serious sign that there is a back injury and that they will go into shock. Okay. So, another kind of pipe failure that they don't talk about here, but just so you know, um, is due to um, infections. Okay, untreated infections. So if you've ever heard somebody say, you can die from a toothache, well, that actually is true. Okay, so it starts off as a toothache and you let it go until it becomes an abscess. Okay, that's a big pocket of bacteria. Well, eventually, anytime you have a little infection in your body somewhere, whether it's a cut or a puncture, you stepped on a dirty nail, um, or maybe it's an infection from the inside. Maybe it's a urinary tract infection. Maybe your appendix ruptured, or you got some kind of a rupture where there's an infection going on the inside. If that goes untreated, that bacteria will start causing havoc on your vessels and they will dilate. Okay, that will cause you to go into pipe failure and you will lose your blood pressure, you will go into shock, and you will die. Okay, so just so you know, these little infections, you think, not a big deal. Yes, if untreated, you will die from these. Okay, I remember I got bit by my cat years ago, and I I took a marker. Okay, and you can do this anytime you get swelling or from an injury. Take a marker and draw around the red area and watch it. Okay, and if you start to notice that it's getting red beyond your marker or your pen that you made, then you know that infection is spreading. And I started to notice that after the cat bite, it was starting to get red up my arm. And so, yeah, I had to go in and get on some antibiotics. And obviously, I survived. But yeah, these little infections, just know that if they go untreated and you start noticing them starting to spread, yeah, you got to get that taken care of. Or surgeries, and you're starting to notice that they're starting to get really red and warm, okay, or even starting to notice pus or whatever. And if you're out in the boonies somewhere, go find yourself some maggots, okay, and then put them in the wound and let them eat dead flesh. Did you guys know maggots will only eat necrotic or dead tissue? They don't eat live tissue. So you think a maggot's going to eat you alive? Well, not necessarily. Yes, you have to be careful, but yeah, maggots are very, very good at cleaning out wounds. We just had a call. I was not on the call, but one of our other medics was on the call, where the woman had some pressure ulcers from laying in bed too long. And yeah, they noticed a bunch of flies in the house. And as they looked closer, she had maggots. She was covered in maggots with all of these wounds. But that's what I say. So, and then there is basically fluid loss. And that's, pretty basic to understand. So, obviously, then we are losing blood, we are losing fluid, and we need to stop that somehow. Now, externally, we can do that, direct pressure tourniquets. Okay. Internally is what we can't deal with. That's where they need a ride and they need a surgeon. Okay. They need us to get them there. So blood escapes from a wound and the system's total fluid level drops. Heart begins to pump faster. Pump eventually stops pumping. Cardiac arrest. Bad things. So once again, external bleeding, easy to detect. Internal bleeding, we look for bruising, swelling, rigidity, severe pain. Okay, so the average adult has about 12 pints of blood. Okay, the loss of 2 or more pints can start to lead to shock. This is why you can go give a pint and you don't keel over from giving a pint of blood. So, shock deprives the body of sufficient blood to function normally. Shock progresses, the body alters its functions in an attempt to maintain sufficient blood supply. So, once again, it starts to shunt blood from areas it does not need. Okay. Now, the body is very good at protecting itself. That's why severe damage, bleeding to certain body parts, um, the body, number one, those vessels are going to start to constrict on themselves to not let as much blood go. And then, of course, platelets are going to start jumping in to try and clot it. Now, a little direct pressure and a little bandaging and tourniquets, we are just helping the body clot. Now the problem is areas where the damage is just too much and the body cannot clot before we go into shock and die. So signs and symptoms of shock: confusion, agitation, restlessness, anxiety, cold, clammy, sweaty, pale skin, rapid breathing, rapid weak pulse, increased capillary refill time, nausea, vomiting, weakness, fainting, thirst. So, as the body pulls blood from the skin, because it doesn't need the skin right now, it's also going to shunt blood away from your digestive tract. Okay, because it does not need food right now. So that's why sometimes when people start going into shock, they start to feel nauseated, and they always say, don't give anything by mouth, but everybody's always thirsty. So uh, don't listen to all the war movies, okay, in World War II where everybody's getting water. Okay. No, we don't want to give anybody anything by mouth. There's only two times where we do, right? That's hypothermia and hyperthermia. Okay, if somebody's too hot or somebody's too cold, we can give sips, but any other shock, nothing by mouth. So maintain the ABCs. So as EMRs, first responders, uh, we treat shock by keeping them warm, okay, providing oxygen, keeping them calm, and any kind of bleeding control, splinting that we can do. So if you're trained to administer oxygen, paramedics and other advanced EMTs, we will start an IV, start giving fluids. Once again, we're giving fluids just as a volume expander. Pump failure is a pretty serious condition. Proper treatment and prompt transport by ambulance to appropriate medical facility will give these patients the best chance. Yes. Anaphylactic shock, transport as soon as possible. Once again, EpiPen, auto-injector. Internal blood loss, they need a surgeon. This guy on the bottom here, this hockey player, I was actually watching this game. I saw this, and a skate went across his throat. So capillary bleeding is the most common type. Then venous bleeding is second most common. This is a little more of a steady flow. And then, of course, arterial bleeding. That's where you're going to see surges of blood, and that's with every heartbeat. So once again, what can we do? Well, direct pressure. This will stop the bleeding for 90% of all wounds, more, 95%. 97.8% of all wounds can be stopped with direct pressure.
Since I work at the hospital, I do a lot of wound cares. So patients' legs are bleeding all the time, yeah, and so I have to put pressure on until before I wrap the leg to get the blood to stop.
Yeah, interesting, isn't it? And
Yeah.
then I suppose you see a lot of patients who are also on blood thinners.
Yep, and then that takes forever to stop.
Yep, yep. So if you know anybody who is taking an aspirin or is on Plavix, if they've got a heart condition, they're probably taking blood thinners. Just know these people will bleed a lot. Okay, it could take a long time to control bleeding. That's why any elderly person or anybody over 65, especially if they are on blood thinners and they fall and hit their head, for us, that is considered a trauma code. Okay, we call the hospital and tell them that we're coming in with a severe trauma patient because more than likely, if they fall, hit their head, they've got a big goose egg, they're probably bleeding in their brain on top of that. Okay, number one, due to age, and number two, with them being on blood thinners, yeah, they're going to be in big trouble if they don't get that taken care of. So direct pressure, you can do a little elevation. Now, there's kind of mixed reviews on elevation, okay? Because if it's bleeding that bad, the body itself actually will shunt blood. It will constrict back on the vessels to that area. That's how the body protects itself. So they've actually found in a lot of research that elevating doesn't do a whole lot. Okay. Um, we still do it. Okay. And nothing has said, no, you don't do it anymore. Okay. We still do it. The hospital still does it. So elevation is still perfectly fine to do. Okay, and then you can also, like, she's elevating the arm here. You can do a pressure point up on the brachial artery. That's on the inside of your bicep, right? Okay, on the brachial artery there, a little direct pressure on the wound and elevation. Okay, that should help you. But really now they're just starting to go to tourniquets. Okay, indicated only in situations where extremity bleeding cannot be controlled by direct pressure or elevation. So there's no rules, or there's nothing you're going to find in your book that says when to tie a tourniquet. Okay, my thought is when you look down at that patient, and if you feel if you feel your sphincter muscle tighten up when you look at that wound and you go, "Oh, that wound needs a tourniquet." Okay, that that would be, if I was going to write that in the book, I would write it just like that. If your butt puckers when you see a bleeding wound, it needs a tourniquet. Okay, so if it looks bad, put on a tourniquet. Now, it used to be in the old days that applying a tourniquet would you would lose the limb, and that really isn't the case anymore. So it can take 2 to 3 hours sometimes. Your muscle cells and skin cells can live a long time without oxygen, without blood. Okay, so it's okay to put on a tourniquet. Put on a tourniquet sooner rather than later. Okay, here's pressure points if you need to. If you just cannot come up with a tourniquet, uh, using pressure points down in the groin and the brachial arteries. Okay, kind of looks like this. Now, something that I have actually used as a tourniquet was my blood pressure cuff. Okay, pump that cuff up and keep it inflated. So, bleeding control. Now, as I said, 97.6% of all bleeding can be controlled with direct pressure. You will be happy to know that all bleeding stops eventually. Okay, does that make everybody feel better? So if you do get blood on your hands, wash it off. Okay, diseases from blood, they do not get through your skin unless you also have a severe cut. Okay, but otherwise, blood on your hands, don't panic. Okay, they don't absorb, diseases aren't going to absorb through your skin like that, not from blood. Okay, a wound is an injury caused by any physical means that leads to damage of a body part. Wounds are classified as open or closed. So obviously closed wounds, the skin remains intact. You might see a bruise. It might be tender to touch, discolored. The skin around it could be really tight, swelling. Open wounds results in the break in the skin. So an abrasion, a scrape, road rash, rug burn. And you see on the picture on the left here, that yellowish fluid, that is plasma. Punctures occurs when a sharp object penetrates the skin, may cause deep injury that is not immediately recognized. Puncture wounds do not bleed freely. This is where an impaled object sticks out of the skin. A gunshot wound is a special type of puncture wound. And a laceration, most common type of open wound, commonly called a cut, Minor lacs may require little care. Large lacerations can cause extensive bleeding. Howie. And then there's avulsions and amputations. So an avulsion is a tearing away of body tissue. Okay, amputated how do you like that? Amputated body parts should be located, and you want to do the double bag. Okay, so if it's somebody's finger that just got torn off, or a big chunk of flesh, or an ear, please, you guys, do them a favor. Put them, try to wash them off as best you can, okay, especially if you've got some saline. Put them in a plastic bag, and then try to get some ice in another plastic bag and put that on top of the ice. Don't put the body part right directly on ice, okay? But keep it cold. This will even let it last even longer, okay? Because some of this stuff they can put back on, okay? They can put a nose or an ear back on, or put a finger back on, okay? So don't discard any tissues, okay? And I know that sounds icky, but if there's a finger laying there, please send it with them. And you can see this one on the left here. This needs a little debriding, a little saline to clean that out would be good. So some principles of wound treatment now. So minor bruises need no treatment. A little ice, okay? Ice the first 24 to 48 hours after an injury. We want to splint the area, stop the bleeding as quickly as possible. So dressing and bandaging are applied to control bleeding, prevent further contamination, immobilize the injured area, prevent movement of impaled objects. So the dressing, this is the object that is placed directly over the wound. Now, this is the one that you want to be as clean, or if not, sterile. Okay, so a 4x4, 5x9, 10x30, anything that's going directly over the wound, you want that part to be sterile. Because what I always tell my first responders is, don't throw out your old bed sheets. Okay, wash them, cut them into strips, and roll them up and put them in your jump bags. Okay, those make great bandages. Okay, or if you need to tie cravats for splinting, okay, those old towels and old linens, okay, they work awesome for that kind of stuff.
Use them for your garden when it freezes.
And use them for, yes, I agree with that. Same with your old shower curtains. Don't throw those out. Put them over your garden for when it freezes. Okay, here's some more dressings. So dressing is what goes on the wound. The bandage then covers the dressing. Okay, here's a triangle bandage, and we'll do all this too, you guys. So wear gloves to avoid contact. Face and scalp wounds. These bleed a lot. Okay, these can really put on a show. So any wounds to the scalp, the head, the face, they really bleed a lot. So just kind of be prepared. Even a little cut, you're gonna be like, geez, where'd all this blood come from? Well, that's what happens. Okay, and then if they're on blood thinners on top of that, it's gonna bleed even more. So direct pressure is good. Now, once we get in class on Thursday, I will show you how to bandage a head wound. So for wounds inside the cheek, hold a gauze pad inside the mouth. Always keep the airway open. So I'll tell you guys, anytime somebody is impaled with something, we do not remove it. Okay? because when you pull something out, this is typically where the tearing happens and the bleeding happens. So we always stabilize the puncture. The only time that we will pull something out is if it's in the cheeks, if it's up through the chin or in the cheeks. And that's because we have to always consider airway, right? ABCs, airway breathing. So somebody's got a pencil going through their cheek. No, we're not going to stabilize it. Okay, we are going to pull that out. Or if it's up through their chin, we always have to consider the airway. Okay, with head injuries, we always have to consider the neck and spine. So we move the head as little as possible, stabilize the neck, monitor the patient's airway and breathing, protect the spine. So nosebleeds, anytime we've got somebody with a nosebleed, I know we see this a lot where you tilt the head back. Okay, we do not want to do that. That started because people didn't want to bleed on their carpets. Okay, um, if you've ever seen anybody throw up uh, partially digested coagulated blood from having a nosebleed and having them leaning back, it's great for the diet because you probably won't eat for a week after that. Okay, um, always lean them forward. Nosebleeds lean forward, and then when you pinch, you don't pinch the nostrils closed. Okay, because you're just creating a dam. The vessels are up a little bit higher. Okay, and you're going to use the bridge of the nose to apply pressure. Okay, because that's where the vessels are. So just pinching the nostrils shut, you're just creating a dam. Okay. Now, temporarily, you might see somebody, who's playing a sport, um, you know, get some kind of a gauze stuffed up there. Okay, that is just temporary. That's once again, uh, that's not going to put enough pressure to necessarily stop that bleeding. Okay, so temporarily, you might see a wrestler get hit and they're going to get gauze stuffed up there. Okay, and yeah, that could help, but really, afterwards, you need to still get direct pressure on the outside of that. Okay, to stop that bleeding. Lean forward and then maybe even a little cool pack across the bridge of their nose. Okay, could help. Okay, eye injuries, when eyes are lacerated is suspected, cover the entire eye with dry gauze pad, have the patient lie on his or her back, arrange for prompt transport. Now, once again, if there's foreign objects uh, in the eye, you always want to bandage both eyes, correct? Because once again, unless you're a chameleon, both eyes are going to be moving the same. So if you got glass in one eye and the other eye is kind of open, watching everything going on, well, just know the other damaged eye is moving with it. Okay, so yes, we always bandage both eyes. Now you can see here that this woman has a pencil in her eye, and they used a little paper cup. They made a hole in the paper cup. Yeah, that works. Okay, and you can do this around the chest or the abdomen as well. Okay, you can use rolls of gauze, whatever you need to stabilize it, wrap it around the body, okay, or wrap it around the shoulder, or they did it around her head just to stabilize it. You don't want things moving. Okay, neck wounds. You can see here they're putting that's called a tegaderm. Uh, it's taped so it closes down all sides. The problem with neck wounds is those big vessels there, uh, air can get in there and cause an embolism. So uh, pretty important to get those bandaged right away, maybe with even using some plastic and then gauze. Okay, you can even use bits and pieces. You can use a sandwich bag. You could use your rubber glove. And then if it's bleeding really bad in the neck, just put a tourniquet on, okay? Is anybody going to debate me on that one?
So yeah, how would you put it?
Thank you. No, no tourniquets around the neck. So in rare cases, you have to exert finger pressure above and below the injury site to prevent further neck bleeding. Major trauma to the neck may be associated with airway problems and with neck fracture or spinal cord injury. Maintain the patient's airway, stabilize the head and neck. Chest and back wounds, place the patient on the with a chest injury in a comfortable position. If a lung is punctured, air can escape and the lung will collapse. The patient may cough up bright red blood. Cover the open chest wound with an airtight material. So once again, just like that neck wound, any chest wound, you can go ahead and use a rubber glove or a piece of plastic, a sandwich bag, and tape it down. Okay, this will help the lung be able to inflate again. Administer oxygen. So chest wounds may damage the heart. So seal the wound and monitor the ABCs. Treat the patient for shock. Perform CPR if necessary. So something to keep in mind. So if you seal up a chest wound and all of a sudden their breathing starts to become more painful and more labored, open up one side of that dressing that you put on, of that occlusive dressing, and let the air out. Okay, and then seal it back up. And that's just something you'll have to keep an eye on. Impaled objects. So my craziest impaled object was a older guy who had been playing poker earlier that morning, and we got called to somebody who was cut. And this is kind of a notorious apartment that we were at. So, of course, I kind of sighed and rolled my eyes, going, "Okay, what they do now?" And got over there, and the guy was sitting down in the office of the apartment complex, and he's awake and alert, and he looks at me, and as I come in, he has a steak knife buried to the hilt just below his xiphoid. So you feel your sternum, and down to that little triangle piece there, that's your xiphoid. That's where he had a steak knife buried to the hilt. Okay. So I felt that pucker that I was talking about. Okay. And I went, "Go." Okay. So what I did was I took a few, you can see on the pictures below here, I took a few pieces of rolled gauze and I put them all around the knife, and then I wrapped it together, and then I wrapped it around his body. Okay. And he lost his life for a minute there. Okay. So he just kind of took this weird breath, and then he went unconscious. And then all of a sudden, it's like he kind of came to and yawned and just went, "Ugh," and he was back with us again. So, yeah, very strange. So then we got him over to the cot, got him into the ER. And when they did the x ray, the knife wound went just to the left of the aorta and just to the very bottom base of the heart. So it missed everything. So what had happened was later on that morning, and from what I understand, he was a cheat. Okay, when he plays poker, he cheats, and he took all of this guy's money. They were walking by each other in the hallway, and what he said was, "I thought the guy punched me in the chest." And no, the guy had a knife, and it was so fast and it went in so fast that all he felt was the butt of his fist hitting him in the chest. And he did live. He lived to cheat at poker another day. So closed wound result from direct blows from blunt objects. Look for bruises or other marks on the abdomen. Watch for shock. So if the patient is vomiting blood, it may be an indication of bleeding from the esophagus or the stomach. Monitor the airway and vital signs. Give the patient nothing by mouth. Arrange for prompt transport. And I'll tell you guys, sometimes if you've been coughing, you've been sick and you've been coughing, and you cough up a little blood, don't panic. Okay. And if your patient says, geez, I just coughed up blood, once again, don't panic. That can happen. Or if you've been really sick and you've been throwing up, or your patient's been throwing up and now they say, oh, there was blood in it, I think I'm dying. Okay. Not necessarily. Sometimes you just tear little vessels. Okay. So anytime there's a little bit of blood in vomit or from coughing up something, and you've been throwing up or you've been coughing a while, sometimes it's just little tears to little vessels in your esophagus, or even down a little bit lower, but most of the time it's in your esophagus. I was going to say trachea, but no, that's not right. Okay, so abdominal wounds, once again, this is where if we can, do an occlusive dressing, we'll try to do that. We're not going to stuff any organs back in. Now, genital wounds like the face, they bleed a lot. Okay, it is very vascular in that area. So the only time we are ever going to inspect the genital area of a patient is if you see a large amount of blood coming from that area. Okay, or if they say, I was stabbed or something happened to that area and you see blood. Okay, otherwise, there will never be any reason why you have to inspect somebody's genital area. Okay, now they were in a severe car accident and you cut all their clothes off, which is totally fine. So you can see everything, that's fine. But there's no reason why you have to expose somebody's genitals or private areas when they're not complaining of any pain or anything in that area. Otherwise, yes, direct pressure is good. Okay, maybe try and get somebody of the same. If it's a boy, put a boy there. If it's a girl, put a girl there. But sometimes you don't really have a choice. Apply dry, sterile dressing. Elevate the injured part for extremity wounds. Splint all injured extremities. So gunshot wounds, if you remember, they said this is kind of a specialty puncture. So you always want to look for an exit wound with a gunshot wound. That's the main thing. Now, it all depends on the caliber of the gun, okay, or the bullet. So a lot of times a 22 might not exit, okay, but the 22 can also do a lot of damage because it will ricochet off of things and bounce around. Okay, it can go in through the skull and actually scramble your brains going around your skull, the top of your skull. Okay, so sometimes a 22, yeah, it's not a very big round. It might not exit, but it can still cause a lot of damage. Now you start getting up to more of the rifles. The thing you have to be careful of is there might be just a small entrance wound, but due to something called cavitation. Now, this is due to the force and the speed going through and how fast the bullet is traveling. It creates a cavity around the bullet as it's going through. So that's why you guys that have ever hunted a deer, okay, and the entrance wound is very small, but then you look on the other side and the exit wound, it has blown out, okay, quite a bit. And that's why, due to cavitation, you're a lot of times you're going to have a larger exit wound than an entrance wound. So always look for the exit wound with a gunshot. Okay, and then as we know, if you have a gunshot wound or if you ever shot, with an arrow, getting some gunpowder on that and lighting the gunpowder on fire and then pulling the arrow through is a good way to cauterize the open wound, okay? So make sure you keep gunpowder in your jump kits, okay? Anybody going to argue me on that one? If you've ever seen Rambo, or to date you even more, Three Mules for Sister Sarah with Clint Eastwood, he used gunpowder to cauterize his wounds. So no, we don't really do that. I know you guys were getting all excited. Okay, so bites can carry high risk for infections, and every bite is reportable. Okay, so this is something where, yeah, we do call the PD for bites. Okay, minor bites can be washed with soap and water. Burns, we need to be careful with burns. Okay, this can, if somebody is severely burned and we add a lot of cool water, this can cause somebody to go into hypothermia pretty easy. Okay, so they still have the degrees: first degree, second degree, third degree. Main thing is I just want you to keep this in mind. Okay, if you don't get the burned area cooled, okay, cooled down, it will continue to burn. Okay, so a first degree will go into a second degree. A second degree can go into a third degree. That's why if you've ever had a really bad sunburn, okay, and the next day you're like touching your skin and it's still like hot to the touch, and then it starts to blister, okay, that's because you didn't get that cooled down. So you got to get the burned area cooled down. And the best way to do this is just cool water. Okay, not super ice cold water, cool water to cool the burn. Sometimes, applying, burn ointments, that you get at Walmart, sometimes that just traps the heat in there. Okay, so now not only are you miserable from the pain, but now you're sticky on top of it. So really cool water. Cool water is the best way to cool a burn. Now, in the ER, in the hospitals, okay, they have different stuff. Something like Silvadene cream for burns is very effective. So yeah, the ER isn't using the aloe cream from Walmart. Okay, they have things, xylocaine, that has a little bit of a numbing agent, that kind of stuff. Otherwise, you guys just cool water. Okay, once again, the extent of burns, they'd still use the rule of nines that you can see here in this picture, but just kind of picture this. If you look at your fist, that is about 1%. So you can kind of gauge too by looking at your fist and kind of going over their burns to see where it was. My worst burns were one guy who was burning his fields, got overcome by the smoke, and by the time the first responders got there, his legs were actually in the fire and were on fire. Um, and my other one was a little old lady who was cooking her breakfast in one of these big, fluffy robes, and she went to move the pan off the burner, and it was a uh, longer robe on her sleeve, and it caught her sleeve on fire. And she was, just being elderly, she wasn't able to remove it in time, and they both ended up dying. Respiratory burns, once again, it's kind of like the chemical burns to the face. We look for soot. Okay, we're looking for burns around the face. The main thing we have to worry about is swelling, airway swelling. Chemical burns, electrical burns. So again, with electrical burns, it's kind of like a bullet. Look for an exit as well. Okay, if somebody grabbed onto something, it's possible that electricity might have an exit out their foot. So multi-systems trauma, this might be a time where you don't see any arterial squirting blood, but there is so much bleeding in so many different areas of the body that you have to put on a tourniquet just so you can work on the other areas of the body. You don't have enough hands to put that much pressure, on them. So once again, don't be afraid to use your tourniquets. Okay, guys, we can um, we'll take a little break here so you guys can get up and move around. Okay, all, welcome back. We'll start chapter 15, injuries to muscles and bones. So EMRs will encounter many types of musculoskeletal injuries: fractures, dislocations, sprains and strains, head injuries, spinal cord injuries, chest injuries. So we're going to go over a little basic anatomy here again. So of course, always scene size up, right? So make sure you have your PPE on. Make sure your scene is safe. Make sure you're parked correctly. Your primary assessment, so level of consciousness, ABCs. Get a good history taking, so ask your appropriate questions. Your secondary assessment. Now, when it comes to lacerations and broken bones, your secondary assessment then is working specifically on that area. So somebody fell and broke their ankle, okay? Well, your secondary assessment, or they call it your focused exam, will be on their broken ankle. So once again, just a little skeletal system review. So you got the head, spinal column, shoulder girdle, upper extremities, rib cage, pelvis, lower extremities. Here's a picture. Five sections of the spine: cervical, thoracic, lumbar. So each shoulder girdle, you have a scapula and a clavicle and a humerus. Radius and ulna for your forearm. The thigh bone is the femur right after your pelvis. The leg then consists of the tibia and the fibula. So muscles of the body provide support and movement. As we know, muscles are attached to the bones by tendons, and bones are connected to bones by ligaments. And then the shock absorbers, that is cartilage. So voluntary muscles, these are ones that we can control. So lifting our arms, that is skeletal muscle. Involuntary, that's smooth muscle. You'll find that on the intestines and the stomach. And this is things that we obviously cannot control. And cardiac muscle is just like striated muscle. Okay, or I'm sorry, skeletal muscle, except that it has its own electrical system to keep it going. It doesn't need the brain to tell it to move. Okay, so 3 ways to get musculoskeletal injuries: direct force, indirect force, and twisting. So you could see here on the left, the direct force was this gal hitting her knee. Indirect force then was her hips separating. This guy here is skiing. And this looks like he should have pizza when he tacoed. So use the information provided by the dispatcher and gathered from the scene to identify possible mechanisms of injury. Okay, use your senses, right? Use your sense of sight and touch. Listen to the information the patient gives you. So fractures, we really only worry about the main 2. Okay, open or closed. Now, yes, there's a lot. Okay, there's spiral fractures and green stick fractures and this and that. We really just worry about, are they open or are they closed? Open means it's through the skin. Closed means that it's not. A dislocation is a disruption that tears the supporting ligaments of the joint. The bone ends separate completely from each other and can lock in one position. Any attempt to move a dislocated joint is very painful. Dislocations can damage nearby nerves and blood vessels. Have a kid in one of my classes who broke his finger during a football game, and the EMT that was out there said, "Oh yeah, I can set this. I've done this a bunch of times." And so he pulled his finger and set it, and he showed me he's got a permanent deformity in his finger because the finger was actually broke. It wasn't just dislocated, it was broke. So if you're ever wondering, do we ever put something back in that appears to be dislocated? And the answer is no. Okay, we do not do this because we don't know if there's a break. So somebody comes up and says, "Yeah, I think I separated my shoulder." Can you think, "Oh, well, I've seen this before. I'm just going to have them pick up this book and then I'm just going to pull here and it'll pop back in." Okay. Well, we don't do that because we don't know if there is a break in there, and we can do a lot more damage if something is broke. So sprains and strains. Sprain is a joint injury caused by excessive stretching. A strain is caused by stretching or tearing of a muscle. So signs and symptoms of extremity injuries, well, pain at the injury site, an open wound, swelling, discoloration, inability or unwillingness to move the extremity, deformity, angulation, tenderness at the injury site. So remember, any injury, we always ice the first 24 to 48 hours. Hey, I know that back in the old days, if you could get a heating pad or a hot bottle on everything, okay, with a physical injury, you're only going to make it worse. Adding ice helps with the swelling, which will help with pain control. All the steps in patient estimate must be carried out, yada, yada, yada. So examination of the injured limb. So inspect the injured limb and compare it to the opposite side. Now, anytime we're going to tie a bandage or splint something, we always have to check a couple of things first, okay? It's called CMS, which stands for circulation, motion, sensation. So what that means is, let's say they fell and they hurt their arm. Okay, so the first thing you're going to do is you're going to see if they can feel you touch their fingers. I'm going to oh, here we go. Hi, guys. Okay, so first thing you're going to do, so they got an injured shoulder. So the first thing you're going to do is say, okay, can you feel me touching? Okay, so feel their fingertips. Okay, can you wiggle? Okay, that's good. So motion, sensation, and now circulation. Always check for a peripheral pulse. Okay, and then always check, is it warm? Does it feel like the other side? And always check the other side. Okay, is it the same color? Is it the same size? Okay, so circulation, motion, sensation. We always do that before we splint a wound, whether it's a bad laceration or it's a broken injury. We always assess it before. Then once we tie a bandage or we splint an injury, we do that full assessment again. Okay, and that's very important because if all of a sudden, you know, you just splinted this guy's arm up like this because he hurt his shoulder, okay, and all of a sudden you go to do CMS, okay, can you wiggle? No, not very well. Can you feel me touching? No, no, I can't feel that. Okay, you're probably pinching something there. You might have to loosen it up, maybe bring it down, okay, or maybe your cravats are a little too tight. So that's why CMS is very important. Okay, when you examine the limb, you may find any one of the following. So an open wound, deformity, swelling. Examination of the injured limb. So when we examine the body and the limbs, we don't go down each side. We actually use both hands on each limb, okay, because we don't want to miss anything. So as you conduct the hands-on examination, ask the patient where it hurts, location of the greatest pain, okay, circulation, sensation, movement. So cover the open wound with dry sterile dressings, apply firm but gentle pressure to control bleeding, apply a cold pack for painful swollen or deformed areas, splint the injured limb. So general principles of splinting then, it prevents movement of the broken bone ends, helps control bleeding, decreases the risk of additional damage, prevents closed fractures from becoming open fractures. Okay, so here's a few splints. Now this is just cardboard here on the left. Okay, cardboard works really, really well. So do magazines. In my jump kit, I've got lots of magazines in there. And I'll show you here that, and we will practice all these things, you guys. But say this is a magazine and you've got somebody with a broken arm. See, this works really rigid. Now, or this works well because it becomes really rigid once you fold it over like that. So you can see here on the left, that's just cardboard. SAM splints, these are pretty effective. So soft splints, a pillow is a splint. Here's an example of an air splint. Traction splints. So this is something where if there's ever a femur fracture and it is dislocated, a traction splint will actually pull on the foot. It's got kind of a little winch on the end of it. So you hook it to the thigh and then hook it to the ankle. And then you start to crank it and it will actually pull the femur bones back into place. I've only used it a couple times in my career. Okay, this is called using a triangular bandage or a sling and swath. So I'm going to go over now some YouTube videos, which you can watch. Because you know me, I'm all about YouTube. Just there we go. Okay, so here's our favorite gal doing the EMR long spine board skill station. This will not be a skill that we will be tested on. Okay, but just watch how they put somebody on a backboard.
Hi, I'm Christy.
Hi, I'm Katie. I'll be your tester today.
Okay.
And these two will be your assistants. You can examine your equipment as I read you the instructions for this station.
Okay.
This skill is designed to evaluate your ability to provide spinal immobilization to a supine patient using a long spine immobilization device. You arrive on scene with an EMT assistant. The assistant EMT has completed the scene survey as well as a primary assessment, and no critical condition requiring any intervention was found. For the purposes of this evaluation, the simulated patient's vital signs remain stable. You are required to treat the specific, isolated problem of a suspected unstable spine using a long spine immobilization device. When moving the simulated patient to the device, you should use the help of both EMT assistants. One assistant EMT should control the head and cervical spine of the simulated patient, while you and the other assistant move the simulated patient to the immobilization device. You are responsible for the direction and subsequent actions of the EMT assistants. You may use any equipment available in this room. You have 10 minutes to complete this procedure. Do you have any questions?
No, I don't. Okay, I'm gonna walk in and BSI, and I'm gonna have you hold C-spine, please. I'm gonna come down and check CMS. I'm gonna check for pulses. Does she have good pulses?
Pulses are good.
Okay. Ma'am, can you feel me touching your hands?
Yes.
Which hand am I touching?
Right.
And now?
Left.
Can you squeeze? Can you wiggle your fingers? Okay. And how about pedal pulses?
Pulses are good.
And which foot am I touching?
Right.
Now?
Left.
Can you push up on my hands? And can you feel me touching you?
Yes.
Okay. Right now I'm gonna measure for a C collar. And how's that feel? Can you still breathe?
Yes.
Okay. And if you'd come down and help me roll, I'm gonna have you put your hands across your chest and we'll crisscross arms. And on her count of 3, we'll roll.
1, 2, 3.
We're going to position the board appropriately. Sorry. And on her count of 3, we'll roll back.
1, 2, 3.
And now we need to move her up as a unit, up and over. So if you want to grab the hips, I'll grab up here, the torso, and on her count of 3, we'll move up and over.
1, 2, 3.
Okay. At this point, I'm going to check and see if she needs any padding behind her torso. If she feels okay to me, I'm going to secure her to the board. And I'm going to secure her head.
You guys notice that she is still holding C-spine. That gal is still holding her head still.
And finally, you can let go of C-spine. I'm going to do one more CMS check. Does she have good pulses?
Pulses are good.
Okay. Can you feel me touching your hands?
Yes.
Can you squeeze? Which hand am I touching?
Right.
Now?
Left.
And pedal pulses?
Pulses are good.
Okay. Can you feel me touching?
Yes.
Which one?
Right.
How about now?
Left.
Can you push up? All right. And I'm done with the station. Hi, I'm Christy.
So the backboard is considered a full body splint. Okay, so if you have multiple injuries, they are considered splinted once they're on a backboard. Okay, so that's why you notice that she did CMS in all 4, right? So she did CMS in her hands by having her wiggle, squeeze, checking pulses, and then did CMS in her feet by having her wiggle, push, pull, and checking pulses. Okay, and then after she got her on the backboard, that is considered a splint now. So that's why at the end, she checked it again. She did full CMS check again. So now let's watch this person splint a leg.
Welcome to the NREMT. That's for padding, should I need it. Angulated fracture of the right tibia. You may use any equipment available in this room. I'm just going to approach my patient, introduce myself. Sir, my name is Kyle. I'm here to help you. And I understand, just making sure this is the injured extremity, the right side. Correct. Sir, can you just sort of help hold your leg in place for manual stabilization? And I'm going to...
One of the main rules to splinting is always splint the joint above and below the injury. Okay, so if it's your forearm, you need the wrist and the elbow immobilized. If it is your wrist, you need the muscles or the bones of the hand and your forearm immobilized. If it's your leg, you need the ankle and the knee. If it's your femur, you need the knee all the way up to the hip.
Assess PMS in the injured extremity. So checking pulse, Fetal pulse is present.
Okay, sir, can you feel this?
I can.
And can you push down on my hand and push up on my hand?
PMS is intact.
Okay. So I'm going to get my padded board splints, measure on the unaffected extremity. Just put those in place for right now. And I'm going to take my cravat and put 2 above the knee, 2 below the knee, making sure not to cover the joint. And I'm going to use the space underneath the knee as a natural void to help slide these into place.
And once again, these are mom's old bed sheets, right? Grandma's old dishcloths.
Similarly, going to use the space below the ankle as a natural void. And just have one final one that I had tied together as the ankle hitch. We'll just slide in place. I'm going to take my board splints, making sure the foam is on the inside. Put those in position.
No knots
going to tie
on
the
the
knots
skin.
against the
Always
side of the
tie your
board.
knot on the board or the stick or whatever you're using. And then if there's a deformity, no ties over the deformity.
I'm just going to go back down one more time just to make sure they're all tight. Lastly, make sure the foot is secured in position to function.
In all these videos, I do expect you guys to know these. So we'll practice, of course, but this is the stuff that I do expect you to know how to do.
Now that the leg is secured, going to double check, sure that I have PMS.
Pulse is present.
Sir, can you feel this?
I can.
Can you push up on my hand? Push down on my hand?
PMS is intact.
Okay.
Is there anything else you'd like to do for this patient?
No, I'm completely.
So CMS before and after, splint the joint above and below the injury, no ties on the skin, so no knots on the skin and no ties over the break itself.
Some extra padding, should I need it.
A secondary survey. Continued assessment of
My scene is safe,
your scene is safe.
and I have my BSI on.
Noted.
I'm gonna come over to my patient, introduce myself, say, sir, my name is Kyle, I'm an EMT, I'm here to help you. And I'm just gonna ask you to just hold your arm just like this to help stabilize the injured area. Just double check to make sure it is the right shoulder.
It is the right shoulder.
Okay, and I'm going to assess pulse, motor, and sensory in the injured extremity. So,
Motor,
checking pulse.
motor, sensory, and circulatory functions are present and normal.
Okay, so pulse is present, sir, you can feel this.
I can.
And you can squeeze my fingers. Okay. Now I'm going to get my 2 cravats. Going to tie a knot at the end to make a small pocket for the elbow. Now I'm going to apply the swath. I'm going to reassess. Make sure everything is secured properly.
Motor, sensory, and circulatory functions are present and normal.
Okay. Pulse is present.
So the sling and swath, this is good for any injury from the shoulder all the way to the wrist. So this is a good skill to have when it comes to people that are having shoulder injuries or any injury of the upper extremity. And if you plan on working in an area where there's potential for people getting hurt, you guys that are going to be on ski slopes and you guys that are going to be up in the mountains somewhere and out in the woods, knowing these skills, knowing these splints is very important. Um, they make factory tourniquets out there, but I like the MacGyver way of showing of doing things. I think this is what you're more than likely going to run into. So using strips of clothing, from your shirt, or using a tornado just blows through your neighborhood and now you're using doors as backboards and woods and twigs and sticks. Using mushrooms to help heal. No, I'm just kidding. That would be cool though.
What we're going to do now is look at improvised tourniquets. Now, you'd only consider using an improvised tourniquet exactly the same as a commercial one if direct pressure has not worked. Now, it may well be that you're out and about, you don't have a commercial tourniquet available, so you need to use whatever's to hand. What we're doing here is using a triangular bandage, but you could use any strong pliable material like gauze material, triangular bandages, clothing. We want to have something that's tight, but also that's not going to be too tight to cause problems. So try and make sure it's at least 5 centimeters thick. Don't use things like wire or string or rope or shoelaces, as this will cause damage. It will just cut into the muscle on the arm. Also things like leather.
All right, this guy's kind of boring. Let's watch this guy.
Hey, I'm Luke Williams, and today I'm going to be showing you how to create a makeshift tourniquet. Now, this is not to be a replacement for a commercial tourniquet. In fact, a little piece of advice, jump online and grab one of these. You can get them from many retail stores like North American Rescue, and then keep it in your car or your EDC bag at all times. Now, all that being said, if God forbid you do come up on an accident or have an accident and you need a tourniquet and you do not have a commercial one, we're going to show you how to create a makeshift one. For this, you're going to need 3 things: some type of material, a windlass, and a securing mechanism. Now, the first thing you're going to need is some material. Whether it's an old shirt laying around, or if you don't mind losing the shirt off your back, you can cut it into a long strip about 1.5 inches wide. You never want to use anything less than that, because at that point you could create nerve damage, which is going to cause way more harm than good. Some other things you don't want to use are cables, ropes, or zip ties. Some things you can use that are great ideas that may be laying around are neckties or scarves. You want to stay away from belts, and even though it's better than nothing, you're likely not going to be able to get the belt tight enough to stop the bleeding. Next is the windlass. This is the object that helps tighten the material around the limb that you're working on. You want something that's not going to break with pressure, so I'd stay away from items like pens and pencils. Instead, I'd recommend using something like a carabiner, a solid stick, or even a closed pocket knife. And last is your securing mechanism. This is basically to keep your windlass from unwinding. Some of the more common things you'll find laying around are the piece that is below the cap on a soda bottle, a key ring, or even hair ties will work. If you have another piece of string or material, you can simply tie your securing mechanism to your limb and lock in the windlass. All right, guys, as I mentioned, this should never be a replacement for a commercial tourniquet. And in fact, when someone arrives on scene with a commercial tourniquet, you want to replace this one as quick as you can. Now, I want to know, who carries a tourniquet with you all the time, and have you ever had to use it? If so, let us know in the comments below, and then make sure you head to Rated Red's YouTube channel and hit subscribe. From the cabin, I'm Luke Williams.
So yeah, that was pretty cool. You know, having that little ring of something, it's actually easier, at least from what I was looking at, that to just use more of your ripped up pieces of clothing to tie it so it doesn't come undone. But that was good information there.
Fired. I need a tourniquet now. I have an officer hit in the leg. Give me cars here, code 10. What are you saying? Right here, and you got it done. 7-9 Baker, bring the flag down on disturbance. Shot fired. I need a tourniquet now. I have an officer hit in the leg. Give me cars here, code 10. Trav, I got you. Watch out. He's moving still. 79 Baker, start ambulance coming down, hit the leg. Step up. Lift your foot up, bud. I got you, dude. You're okay. 79 Baker, he's going to be in the 500 block, right in front of a silver Jeep. He's still moving. My partner's putting my tourniquet on right now, so I'm not able to get him into custody yet. Mark this time for tourniquet time. The black male, he apparently just robbed at the 7-Eleven. He still has the cash register in hand. I got.
So kind of interesting there, just to see how quick a tourniquet can be applied. Now, looking at his wound, I'm you know, it's hard to say. I'm not there, so Was there a lot of blood coming from the leg? Was it pulsating? Did he need a tourniquet? You know, maybe, maybe not, but tourniquets kind of started coming more into play from being at war for the last 30 years. And what that tourniquet did is not only did that keep the hurt officer in the fight, but it just took a minute, so that kept the second officer in the fight as well. So you guys that are going to be police officers, kind of keep that in mind, that that's why tourniquets are very effective. It's a quick way of stopping the bleeding, so you and your partner can obviously still take care of yourselves. And that was actually pretty good timing, because I think I will be finished at that point. So that's okay that that video stopped. So I will stop us here. Does anybody have any questions?